Welcome everyone to our patient educational webinar. Today we are going to talk about cochlear implants and answer all the questions that you may have. Okay, let me advance. All right, so these are today's presenters, and we are fortunate to have Dr. Varadarajan. He is a neurologist from Sacramento ENT to join us today. So thank you very much, Dr. V, for joining us today. And my name is Dr. Gail Amon-Pongshai. I am an associate clinical professor at UOP Hearing and Balance Center in Stockton. We also have a representative from Cochlear America, Dr. Angie Wen, who will be joining us today. So thank you very much, Angie, to come and present today. I would like to introduce you to the staff at UOP Hearing and Balance Center. This is the team members at our Stockton clinic. There are two audiologists, myself and Dr. Awad, and Cherry and Iris, who are our admin staff. And if you don't know, UOP also has a graduate program in audiology located in San Francisco. Over there, we have a big academic program as well as a larger clinic. These are the photos of some of the faculties and staff who teach and see the patients in San Francisco. All right, so here is today's agenda. We are going to talk about cochlear implant candidacy, and we are going to talk about what is cochlear implant, the implant journey, and what are the expectations and outcomes of the implant, as well as insurance coverage. And at the end of the presentation, we will have a lot of time for you guys to ask any questions to me, Dr. V, or Angie. All right, so who are a candidate for cochlear implant? Cochlear implants are designed for people with moderate to severe sensorineural hearing loss, which is the hearing loss that is caused by damage to the inner ears, or maybe a damage on the hearing nerve pathway that leads to the brain. There are many types of hearing loss that the patient can have, and your hearing loss is used to determine the right type of the treatment. For example, treatment options could be hearing aids, it could be cochlear implants, it could be surgery, it could be medications, and etc. So it is very important to receive comprehensive evaluation and consult with your audiologist to determine what treatment option is right for you. So let's talk about sensorineural hearing loss. Okay, sensorineural hearing loss is the most common type of hearing loss, and it occurs when the inner ear or the cochlear or the hearing nerves are damaged or doesn't work properly. So this is a nice picture that show healthy hair cells in the inner ear versus the hair cells that are damaged. And the damage could be caused by age, as we get older, the hair cells may get weaker over time. It could be caused by exposure to loud sounds. Exposure to loud sounds could definitely damage hair cells and the hearing nerves, causing hearing loss. Hair trauma, genetic is can play a big role. Some people have better genes to protect our hair cells against, age-related hearing loss or noise exposure. Some people don't. Meniere's disease. This is a condition where there is an increased amount of fluid inside the inner ear, causing sensorineural hearing loss. Or some medications, for example, strong antibiotics or chemotherapy medication could cause a damage to the hair cells inside the cochlear. Congenital, some people are born with hearing loss at birth, so that could be sensorineural hearing loss as well. So these are the common causes of hearing loss. Treatment of hearing loss, sensorineural hearing loss, typically start with hearing aids. okay? Hearing aids are devices that help amplify sounds to be louder. However, in certain cases, when there is a lot more damage to the inner ears or the hearing nerves, the ability for patients to understand speech is affected, and patients may no longer benefit from hearing aids because even though they can hear, speech might not be as clear. And this is when audiologists will recommend a cochlear implant as an alternative option. Sorry. See, okay. So sensory neural hearing loss can also happen in one or both ears. When it only occurs in one ear, for example, maybe due to infections, condition like Meniere's disease, head injury, or unknown reasons, patient may have hearing loss in just one side and the other ear is normal. Okay, so in this picture, the right ear has severe hearing loss while the left ear is pretty normal. It's just a little bit of hearing loss in that ear. So we call this a single-sided deafness. And treatment options for single-sided deafness include cross hearing aids, and that's a traditional treatment option. So cross hearing aids, some of you may wear this right now, is when you have a deaf ear. So you cannot really amplify that ear with a hearing aid. So what they wear is a microphone, really a microphone device that picks up sound from the poor side and wirelessly transmit the sound over to the good side. So therefore, cross hearing aid doesn't really help a patient improve the hearing loss in the poor ear, but only transfer the sounds to the good side. Cochlear implants, on the other hand, is a treatment option that amplifies sounds in the deaf ear. And it allows the patient to hear out of that ear. So this is a treatment option for single-sided deafness as well. And the good news is FDA recently approved cochlear implant as a treatment option for single-sided deafness. Okay. Okay, so now let's go through some of the solutions of sensory neural hearing loss again. So we talked about hearing aids. When you are diagnosed with sensory neural hearing loss, you will typically prescribe hearing aids. And hearing aids are devices that capture sounds and make sounds louder. They are appropriate for patients with mild to severe hearing loss and have some remaining healthy sensory hair cells. So that the hair cells could transmit sounds from the ears to the brain using amplification. And why is this important? It's because we need healthy hair cells for sounds to be transmitted to the brain. If the ears are so damaged, for example, from exposure to loud noise, then the patient may hear sounds louder, but hearing aids might not be able to clarify the speech and help too much with the understanding of speech if the damage is done, if there's a significant damage to the ears or the nerves. So what are some signs that the hair cells or the hearing nerves are significantly damaged? If the patient experience more difficulty hearing conversations, especially in noisy situations, and frequently ask people to repeat themselves. If they have trouble hearing on the telephone, if you find yourself agreeing, smiling, or nodding conversations, even though you're not sure what is being said. If you rely significantly on lip reading, or you have single-sided deafness. So these may be some signs that hearing aids might not be enough. All right, so that's when cochlear implant may be a better option. Okay, so cochlear implants are designed for those with moderate to profound hearing loss in one or both ears, and those who have poor speech understanding ability. So let's look at this graph. This is a fitting range. The yellow is a fitting range of cochlear implant candidate. If you don't know this graph, this is an audiogram that plots the softest sound that you can hear. From left to right is frequencies. So left is low frequencies, right is high frequencies. The lower it goes on the graph, the more hearing loss. So normal down to profound hearing loss. So if you are a cochlear implant candidate, your hearing loss should fall in the yellow range here, so moderate down to profound. Also, we look at the speech understanding score, okay? And that's very important. So some people have poor hearing loss, so hearing loss that may fit this range. However, their understanding score might be really good, and they might not be a candidate for cochlear implant. If you have poor understanding score and the fitting range here, you may be a candidate for cochlear implant. Now, cochlear implant consists of two parts, which we'll talk about later, just in a little bit. The internal processor is what the surgeon, like Dr. V, implant inside the head. And the patients still wear external processors. Either one of these, this is the over the ear and this is off the ear, which I will be talking about in just a second. It is important to understand that we hear better with two ears. The benefits of binaural hearing include a better understanding in background noise, improved sound localization, or be able to localize where sound is coming from, and better sound quality overall. And therefore, even though the patient receives an implant on one side, it is recommended that that patient continue to wear a hearing aid on the other side, so the patient can receive benefits from binaural hearing. Alternatively, patient may choose to receive a second implant after they receive the first one, and this is called bilateral hearing, or the patient is wearing two implants, one on each ear. All right, and Dr. V, this is your slide.
All right, just turning on my microphone and camera. Can you guys see and hear me yet? I'm trying to.
Yes, we can see you.
You may not be able to see me because
of the slide, yeah, but we can hear you.
I can hear you. Okay, perfect. Sorry, I'm trying to make it so. I see Gail is the only one showing up. I'm trying to get the slides to come back. Hold on one second. Got it. Okay, so I'm going to be talking about the cochlear implant itself, the surgical process, and really what it's like when I counsel patients about the surgery, what to expect, and the mechanics of how it's actually working. You can go to the next slide. So as we've been discussing, the cochlear implant really consists of two separate components. On the left is what we've been talking about, is the external sound processor. There are a couple of options there from Cochlear Americas. The right is the internal piece that I'm putting in. And so we call that, the surgeons, we call that the stimulator receiver, or receiver stimulator, because it receives the signal from the external piece and it transmits that signal and provides stimulation directly to the hearing nerve. Now, it's kind of a small image, but on the right side of the slide here, you see a round area at the top of the implant. That round area contains a magnet, and that magnet is what couples with the external piece through the skin. So that magnet sits underneath the skin, behind and above the ear, and there's an area above and behind the ear where the external processor's magnet will couple directly to that. So there's nothing sticking out through the skin. The whole surgery is done through an incision placed behind the ear. This implant also, as you can see, has two, I think the slide changed. There we go. Has two wires connected to it. Okay, good. The same image is on the top right. There's two wires connected to it. The one to really pay attention to is the one with a little curl at the end of it. That is actually, there we go. Thanks for showing it with the mouse. That curl is actually the electrode that sits inside the cochlea. And they may not always be curled, but this is a great example of one that's sort of what we call pre-curved. So it hugs around the inside of the cochlea, like the diagram you can see below. And you can see all those little white stripes on the electrode. Those are electrode channels or electrode contact points. Now, to step back from this for a second, our ears as mammals are just antennae. They pick up sound vibrations from both sides of the head, assuming you have two functioning ears. The function of the ear canal, then the eardrum, and the three small hearing bones behind the eardrum are to transmit that vibrational energy of sound into the inner ear and the cochlea. The cochlea itself, its function is to convert the vibrational energy into an electric signal, because the hearing nerve in the brain only communicates through electricity. So all of our five senses, their job is to convert whatever sense, whether it be hearing, taste, vision, it converts it into an electric signal for its respective nerve that communicates with the brain. A cochlear implant bypasses all of that. It gives the electric stimulation that the hearing nerve wants directly to the hearing nerve, so that way the non-functioning cochlea and ear no longer have to do that, because realistically they can't. And so we're bypassing that whole apparatus of mechanical or mechanoelectric transduction directly into electric stimulation for the hearing nerve. Now, the internal implant I mentioned, we call that the receiver stimulator. And there's different types of electrodes that can go in the cochlea. As surgeons, we sort of pick what we think is best, but most patients, it doesn't really matter, and we can go with whatever we have a preference for surgically. Sometimes if there's patients with a lot of regular residual hearing, like I say regular meaning the natural hearing that we have, we sometimes choose electrodes that have a greater chance of preserving that natural hearing, so you may not necessarily be completely deaf after the electrode is put in. And so you'll see, if you Google this, you'll see various different electrode types, and there's benefits and drawbacks of each one of those decisions. In general, though, the more of the hearing nerve we can stimulate, the better the hearing experience. Also, if we're able to preserve any natural hearing, sometimes patients can use not only a cochlear implant in that ear for the high pitches, but also a hearing aid for that ear in the low pitches, for the ear's natural ability to hear, and they get even more satisfying and rich hearing experience. You can go on to the next slide. So we can go to the next one as well. Gail, I think these are your slides. I know we wanted to save questions for the end, but
Yeah.
I can talk more about the actual surgery details a little later. But are there any questions on how the implant actually works or the internal piece of it?
Let's wait for the questions until the end.
Okay.
Because I'm going to actually show the video, a nice video of how the implant works. And this would kind of go well with what you talked about. Yeah.
Very good.
The Nucleus cochlear implant system is designed to mimic the functions of the human ear. Sound travels to your ear and the sound processor, which sits behind the ear. The microphones on the sound processor pick up sounds, and the processor converts them into digital information. This information is transferred through the coil to the implant just under the skin. The implant sends digital sound signals down the electrode into the cochlea. The hearing nerve fibers in the cochlea pick up the signals and send them to the brain, which is translated as the sound you hear. Unlike a hearing aid that simply amplifies sound, cochlear implants send sound directly to the hearing nerve and on to the brain.
All right. So that's how the cochlear implant works. I want to talk a little bit about the sound processors that the patient will be wearing on the outside of the ear. Without the sound processor, really no one will know that you have an implant, because everything is implanted inside the ear, inside the head. And you can only hear sounds when you start, you attach the sound processor to the magnet that is surgically implanted right under the skin. When the external processor is communicated with the internal processor, that's when you're gonna hear sounds. Okay, so there are two types of external sound processor that you can choose. One is called over the ear. This is over the ear. It looks similar to a hearing aid, but it has a coil that goes up to attach to the side of the head. The patient may also select an off-the-ear solution like this one. So the whole components of the implant is within this device. There is no coil, so the device is just attached to the side of the head. Now, this solution, though, is not going to be appropriate for someone who has a thicker skin or someone who wears a cap or a hat a lot, because the device often fall off easily. So it's not as secure as this style. All right, so we are going to talk about the journey. What is the journey to receive a cochlear implant? And we will go over the process to determine candidacy, the surgical process, programming appointments, and what to expect after the patient received the implants. All right, so the journey starts with a comprehensive hearing evaluation. And this is not just a regular evaluation, but what we call a cochlear implant evaluation to determine if you are a candidate for cochlear implant. If you have not seen an audiologist, you will need to schedule an appointment with one, or if you already seen one, just mention to your audiologist that you're interested in cochlear implant. The audiologist then will schedule a cochlear implant evaluation appointment. This is an appointment that involves testing to evaluate your speech understanding ability with hearing aids to determine how well you hear and understand speech with your hearing aids, or with the hearing aids. And based on these audiometric results, audiologists will determine if you are a candidate for cochlear implant, discuss expectations and factors that determine the outcomes of the implant. And if the patient decides to pursue implant, then they will be referred to an ENT surgeon like Dr. V for medical and surgical consultation. All right, Dr. V, this is yours.
Yep, thank you so much. You can go on to the next slide. We'll get right into. Right.
Okay, here.
So,
I think this is it.
Perfect. Yeah. So before jumping actually to implant procedure of what it takes, when a patient sees me, there's two categories of patients. One is patients who've never heard about a cochlear implant, and I'm the first one sort of exposing them to the technology. But the majority of patients have actually been evaluated by an audiologist, like Dr. Mornpongchai or Dr. Awad or a hearing instrument specialist. And the idea of a cochlear implant has been introduced already. And they sometimes have already been determined to be a candidate audiologically, and they're just meeting me to learn about the surgery. As far as the medical workup, let's make the assumption that they are a candidate from an audiologic standpoint, meaning their hearing is bad enough based on FDA criteria and the patient's insurance criteria to justify talking about a cochlear implant. With that assumption being made, where's the medical workup take us next? I have a long conversation with the patient about the history of their hearing loss. Is it on both? Is it on both ears or one ear? Has it been gradual loss? Is it a sudden loss? How long have they been deaf, or how long have they had any sort of hearing loss subjectively? Have they had any surgeries in that ear before that could impact what we want to do? Do they have any other symptoms, for example, dizziness or anything else that could complicate our medical workup? I examined their ears carefully under the microscope that we have in the clinic to make sure there's no contraindications or reasons we should not be doing or offering a cochlear implant. And I also order imaging. We at the very least, we order a CT scan of the temporal bone, which is the part of the skull where the inner ear is. And that gives us a picture of the cochlea, and it tells us, has the cochlea formed appropriately? It tells us, is there any inflammation or infection that the patient's not reporting that may also serve as a contraindication for the procedure. It tells me, are there any anatomic variations or anything the patient was born with that may complicate the procedure. And if that all looks good in the routine patient, that's all we need from a medical workup standpoint. Some patients, we also end up getting an MRI. These are patients who also have dizziness, patients where one ear is not hearing the same as the other ear. We want to make sure there's no explanations or etiologies to the level of the brain that could be causing that. We also want to make sure in those cases that there is a visible and well-functioning hearing nerve. We can visualize that. We actually can visualize that on the MRI. In the other patients, we talk about their other medical history. For example, if they have heart or lung issues, they may be taking blood thinners. We get medical clearance for those patients from either their primary doctor or from the specialist that's prescribing their blood thinners to get permission to stop the blood thinner if we can. Now, some people, they cannot stop their blood thinner. It just slightly increases the bleeding risk during surgery, but we end up offering it regardless. And once all these once all these boxes are checked, we can say, okay, we can go ahead and schedule the procedure. The procedure itself is outpatient. For routine cases, it takes well less than an hour. Usually about, it says on here 2-hour surgical time. Honestly, it takes me about 40 minutes to do the actual surgery from when you make the incision until you're closing the incision or the incision is closed. The more challenging cases can take over an hour up to 2 hours. More than 99% of people, it's performed under general anesthesia. There are more and more protocols being published now about doing it under heavy sedation for patients who cannot be totally put to sleep. Not all surgeons will offer that, and I'm currently working on a protocol here to be able to offer that with, I just got to find the right anesthesiologist who's willing to work with us on that. But there's an incision, like I mentioned before, behind the ear, and we work through that incision to put in those components of the internal device, which is that flat metal plate with the magnet that we put that underneath the skin behind the incision. And then I work through that hard bone. If you feel behind your ear, you feel a hard lump. That bone is called the mastoid bone. And we work through that bone, which is actually hollow. That connects straight to your inner ear and gives us access to the cochlea. That mastoid bone is kind of like another sinus, just like your cheek sinuses, but it's sort of the sinus of the ear. And that's how we gain access to the cochlea. We stitch up that incision. All the stitches are dissolvable. And then we have you wear a dressing or a head wrap for usually 3 days, although it can give or take a day or two, depending on what your surgeon prefers. And typically within the next few days, patients return to their normal routine. The biggest thing is for a couple of weeks, we don't want strenuous activity. And that's true for any type of surgery you undergo. And we do limit air travel for a few weeks after that. And the internal component, it's meant and designed to last a lifetime. So you're not supposed to have to replace that. And there's an extremely rare failure rate with Cochlear America's devices, where I've never even seen one fail, knock on wood. And so patients who get implanted as a child, we expect for them to continue to use that throughout their life. We can go on to the next slide here. Like I mentioned, the recovery, most people tolerate it very well. There are some patients who do feel some dizziness afterwards, and that gets them a little slower to recover from that. The dizziness typically resolves in a few days, and about 10% or less, it lasts a few weeks. And a very small percentage of people, it lasts longer than that, and they actually need something called vestibular therapy, also known as balance rehab, or it's like physical therapy for your balance. And later I can even talk more about surgical risk. But you can go to the next slide. Once they're totally healed up, I usually see patients 1 week afterwards, and I give them clearance to get it turned on. And the word for turning it on is called activation. And so obviously the company here requires 3 to 4 weeks before you turn it on. I do push that boundary a little bit. If they look good in 1 week, I give them clearance, and they can get it turned on anytime they want, anytime they can essentially get in with the audiologist to do so. And you can go to the next slide.
All right, I can.
Activation day. I think Gail, I think you were going to be discussing that more in detail, but that is when the audiologist actually gets you the external component. You wear it, you get it turned on, and then you start your hearing rehab journey.
Right. Can you guys hear me okay?
Gail, you still there?
Yes. Can you hear me?
Yep, we can hear you now.
Oh, okay. Let me just make sure. All right. So I can talk about the activation day, and this is a day that the external the implant processor will be activated, which is about 3 to 4 weeks after the surgery. Let me see if the subtitle is not coming on, but I'm sorry. Okay, here we go. This is an exciting day because this is the day that we turn on the processor and program it. So it's the first day that the patient hears through the implant. The processor will be set to a level that is comfortable for you to wear during the first month. Now, let's talk a little bit about what to expect when the implant is first activated. It is important to know that cochlear implant doesn't amplify sounds like we normally hear, right? It sends electrical signals to the hearing nerves and bypass the damaged hair cells in your ear to help provide the clarity that you won't get with the hearing aids. Therefore, when the implant is first activated, most adults report that the sound quality is not clear. It sometimes sounds like beeping or robotic. However, the sound quality most often improves over a period of time. So as the brain adjusts to the electrical stimulation, next month, 3 months, 6 months, the patient return to see the audiologist for follow-up programming appointments. And during these appointments, patient will indicate if they hear what they hear through the implant. And based on the responses, a new map or program will be created, which allow more sound simulation and subsequently improving the patient's understanding of speech. So this leads us to the next slide. What do implant users need to do in order for the brain to learn new sounds? So after the implant is activated, it is very important for the patients to spend a lot of time practicing at home, learning to interpret these sounds. Patient will be given listening exercises to do at home with the implant. For example, we ask them to watch television with closed caption on, or reading and listening to an audio book through the cochlear implant alone. And doing these exercises really help the brain integrate what they hear through the ears and what they see through the eyes to adjust for the brain to adjust to the new sounds faster. The more exercises that you do, the better the outcome is. The good analogy of the importance of listening exercise following the surgery is similar to a knee surgery. So when you receive a knee surgery, you get a new knee. Patients need a lot of physical therapy to strengthen the muscle around the knee and to reduce pain and swelling and restore that range of motion back. Listening exercises after the cochlear implant is activated is the same. We call this oral rehabilitation, and it is crucial to the success of the cochlear implant to improve speech understanding and helps the brain adapt to electrical sounds. Aside from your audiologist and your ear, nose, and throat doctor, Cochlear America is a great company, and they provide a very good support before and after the patient receives the implant. Sherry Edwards is Cochlear America engagement manager, and she helps support patients who are looking to get the implant and answer all the questions that they may have up until the day they receive the implant. If you have any questions, you're not sure if the implant is the right solution for you, we connect you with Sherry to answer all the questions that you may have. Jessica Brock is a recipient solutions manager, and she assists patient after the patient receives the implant. So she will go over the device orientation, listening exercises, and all the wireless accessories that the patient may need with the implant. It can be like a TV connector, connecting the implant with a cell phone for the direct streaming, and etc. So we work with these amazing people to assist you through the implant journey from the start to the end. All right, so now we are going to talk about outcomes and performance, and this is Angie.
Hello, can you hear me?
Yes, we can.
Okay, hi. So my name is Angie. I work for Cochlear Americas, and I'm going to be talking about some of the outcomes, potential outcomes that when you're getting the cochlear implant, you could have improvement on. So knowing that a hearing aid might not be working for you as well, as you're struggling with clarity, to speech understanding, especially in noise, when you're in your family situations, a cochlear implant might be the best solution. So in this slide here, you can see that the pre-op in the blue, this study shows that the patient are getting about 10% in a noisy situation. So when they're getting a cochlear implant, post-operatively, they are getting about 72% improvement or 72% scoring. So that's about 60% improvement right there, especially in this study where they're saying it's in a noisy environment. So you could see that you're getting that improvement at least in one cochlear implant. You want to move forward? Yeah. So Cochlear has done a lot of studies and collaborated with a lot of different academic centers and clinics, and they're really showing comparison to what you would get out of 2 hearing aids versus an adult versus getting a cochlear implant. So generally, what you will be getting is a an improved ability to hear your TV 5 times more than what you are getting now, 7 times more to understand sentences, and then of course the ability to hear on the phone is very important. And nowadays, it's 11 times more than what you would be getting now. So we are seeing a huge improvement from where you would be getting your hearing aids currently. So there's many outcomes of your, how you're doing and your quality of life. So what we're seeing with a cochlear implant, that you are getting that speech understanding back, your clarity and your language, you're communicating more with your families and your friends. You're going to be understanding in noise more than what you're hearing, especially in a restaurant and your family gathering. Your quality of the life is going to improve, and especially if you are still working and you're employed, you're able to perhaps, some definitely patients who are struggling with hearing, you might be struggling to get a promotion or something, or you're too afraid to do presentations or talk to different clients because you're not able to hear. So this will give you that life back. So definitely want to go and visit University of Pacific and talk to an audiologist about this. Okay. So you don't wait until you really lose your hearing, because we know that if you have some hearing still, it's actually a better improvement and faster improvement with a cochlear implant than waiting all the way to your bottoming out to where your hearing is like 0%, because we know that a cochlear implant will improve your life and your quality of life better. So, and of course, just to remind yourself that it does take, if you're motivated to hear, and you're putting in the work, just like what Gail said, that therapy, it's just time, patience, support, your success with a cochlear implant is going to be there.
All right, thank you, Angie. And the last slide, I'm going to talk a little bit about the insurance coverage on cochlear implant. So unlike hearing aids, cochlear implant surgery and the device itself are typically covered by private insurances, Medicaid and Medicare. However, follow-up programming visits, so after the implants are surgically implanted in your ears, the follow-up, the programming visits and the services for cochlear implants are typically billed to your insurance. And it is important to know that not all the services involved in the follow-up visits are billable. Therefore, you may be responsible for some of the programming costs of the cochlear implant. Okay. All right. And that's all we have. If you are interested in pursue cochlear implant or learn more about it, I encourage you to book appointment at either of our clinics. This is the phone number for the Stockton Clinic, and this is for San Francisco Clinic. Or you can visit our website at hearingclinic.pacific.edu to learn more about what we do. And is there any questions? It's time for questions and answers. So I'm going to ask Dr. Awad to moderate this question and answer.
So I actually got a
section.
couple direct messages from one of the participants. The first question was, if you have hearing before you get the cochlear implant, will you lose it when the implant is done? And also, if you retain natural hearing after the implant, can there be a problem with synchronization that can cause fuzzy hearing? And these are really good questions. To address the first question, it's a yes and no. So yes, there is some degree of losing some residual quote unquote natural hearing because we're going to go over a little anatomy. The cochlea itself is the hearing nerve, and the little cells, the hearing cells, we call them hair cells in the inner ear, are actually organized based on tone. We call that tonotopic organization, just like the keys of a piano. And the lowest part of the spiral is where the high pitches are, and that's where we actually open up the hearing organ to put the electrode in. And the tip of the cochlea is where the low pitches are. With most patterns of hearing loss, for example, age-related hearing loss, we lose the high pitches first, and then we keep the low pitches for longer. And when we open up the cochlea and put the electrode in, just because of proximity, we're going to be losing any residual hearing in the high pitches and likely the mid-range of natural hearing. However, cochlear implant candidates, the typical patients have already lost their hearing in these regions, and the best sort of place that's preserved from a hearing standpoint are the low frequency or low pitches. And so as we put that electrode in, it is certainly possible to be able to preserve that low frequency residual hearing. And that's where the answer is also no. We may not lose that hearing. And in situations where we really try to preserve that low frequency residual hearing, well more than 2/3 of patients were able to preserve it. In some studies, we're preserving more than 70, sometimes 80%. And to answer that second question of, does it sound fuzzy? In the beginning, the whole thing sounds fuzzy, and it's not going to click or synchronize right away, but with practice it does. And one day it does click and it sounds more natural. And if you do have residual acoustic hearing or natural hearing, it sounds even more natural than a cochlear implant alone. That's not to say that the patients with the cochlear implant stimulation alone, don't feel that natural sensation. A majority of those patients, greater than 90% of those, also feel like it just becomes like a natural type of hearing over time. Now, the second question from Edward was, what happens to the magnet in an MRI scanner? All of our current FDA-approved devices are MRI compatible. so nothing happens to the magnet. The older devices, sometimes we needed to put a head wrap around patients for an MRI, but now they are all MRI compatible.
I think Glenda had her hand up before we get to the other questions in the chat. Go ahead, Glenda.
Thank you. My question relates not only to hearing, but to balance. And I'm seeing my hearing diminishing, and at the same time, my balance is getting worse. So I wonder if you could address this, and would a cochlear implant, for instance, help me also with balance? And I do balance exercises, but the fact that both are diminishing at the same time makes me feel they are connected.
That's a really good question. The short answer is no. The cochlear implant, I would not expect any significant improvement in your balance function just from the cochlear implant. It's just because of its effect. That being said, untreated hearing loss, one of the risks of not treating it is an increased risk of fall. And we haven't exactly pinpointed the link there. Is it because patients are more aware of, there's some degree where hearing and balance are intimately tied in, and there's no evidence to say that if you get a cochlear implant, your fall risk is lower, but it's more so you may just be more aware and you have another sense to be able to perceive your surroundings. As hearing and balance both deteriorate, that's a very commonly reported thing. There's a lot of other things that deteriorate as well, including, our vision and including our musculoskeletal systems, and both of those also play a role in balance. And we can't just say it's the ear; it's actually a multi-sensory deterioration that we get with aging.
Thank you.
What is the cost of these?
So, like I said, Medicare and Medicaid and a lot of private insurances cover the cost of the surgery, the implant surgery and the device, depending on so following after you receive the implant, you need to work with the audiologist for programming visits, for programming appointments. And depending on the location, some may charge for the programming visits, some may not. So it just depends on where you go for the programming.
How do you figure that out then?
You just have to inquire that beforehand.
Talk to who?
So it just talk to, the receptionist. So UOP, for example, we do charge for the first year, we do charge about $1,500 for the programming that are non-billable to Medicare. So programming visits because the first year we do see patients about 10 hours in the first year. So that's just the first year, and following that, there's really no cost to the patient.
Thank you.
The surgery is covered, by the way, assuming we get prior authorization. Our surgery scheduler works with our billing department. You probably will have whatever, depending on the insurance, some sort of deductible that has to be paid. But beyond that, if you're a candidate based on insurance guidelines, the surgery is covered.
Okay, the next questions are about the effects of how does a cochlear implant affect tinnitus? Does it make it go away, or does it make it worse?
Good question. Nothing will ever make tinnitus completely go away, but the vast majority of patients do report improved tinnitus long-term with the use of their cochlear implant. Now, in the short term, it might actually make things worse before you actually get it activated and turned on, because there's a change in, the microenvironment in the ear. There may be some inflammation that increases the tinnitus. But once we start using the implant, it actually provides auditory stimulation to the brain, and the tinnitus is coming from the brain, and the brain perceives that and downregulates that tinnitus in the vast majority of patients.
And if you don't have any questions, I'm going to end the webinars today a little earlier. But thank you very much for everyone to attend the webinar, and thank you, Dr. V and Angie, to join us on the presentation today.
Thank you, everybody.
Thank you.
Thank you.